So a very warm welcome to you all. Thank you so much for joining us for this, the fourth event in our ongoing Emerge series. I'm Maggie Harrington from Orphan Australia, and I'm honored to be hosting this event. The topic of tonight's session is ROTEM in COVID-19, a topic which seems especially timely for us in Australia currently, as I imagine many of us on the call tonight are joining from a region affected by one of the current lockdowns. So before we dig into tonight's presentation, I just quickly want to re-highlight the purpose of our Emerge events. Emerge stands for Education Meetings for Expanding ROTEM Guided Excellence, and the aim of the series is to highlight evidence-based best practices for improving outcomes for bleeding patients. The core focus of these sessions is to harness the knowledge transfer of ROTEM-guided patient blood management strategies to enhance patient safety, optimize resources, and reduce costs. We hope you find these sessions worthwhile, and we are always grateful for any feedback you may have of how we can improve the sessions to make them even more valuable for you. So really quickly, I'm just going to touch on some housekeeping items for tonight's event. First, we will be following up with you via email with a really short survey. So please take a moment to share your thoughts with us. Your feedback is really important. And next, I'll just go through some technical details regarding this Zoom session. First, please be aware if you didn't see the notification that the meeting is being recorded. And I also want to let you know that we will have several poll questions integrated into tonight's presentation. The poll responses are completely anonymous, so please don't worry about getting the answer wrong. We just really want to encourage everyone to participate as a learning opportunity. We'll keep the poll questions on screen for about 30 seconds before removing them and showing the results from the group. We'll also be holding a Q&A portion following the presentation. So please feel free to type any questions you have in the chat, or if you prefer to ask them verbally, feel free to wait till the Q&A portion where they will be addressed by our expert speaker. We will, of course, do our best to answer all questions live during the event. But for any questions we aren't able to get to due to time constraints, we will be sure to publish a list of questions and answers in an email following the event. So finally, it's time for some quick introductions to quickly introduce the members of our Orphan Australia team. We first have from Brisbane, Craig O'Sullivan, our Acute Care Diagnostics Product Manager and Business Unit Manager, and also in Brisbane, Natasha Curie, Clinical Application Specialist who covers the ROTEM training and education throughout Queensland. Next, based in Perth, we have Julia Bonser, Clinical Application Specialist who looks after ROTEM training and education in Western Australia, the Northern Territory, South Australia, and Tasmania. From Melbourne, we have Azadeh Zargari, our Systems Specialist who looks after ROTEM training and education throughout Victoria. And we also have with us tonight Kieran Pickles, our National Sales Manager, and Peta Samaras, our Acute Care Diagnostics Product Specialist, both based here in Sydney. And once again, I'm Maggie Harrington, also a Clinical Application Specialist. I look after the ROTEM training and education in New South Wales and the ACT. And last but certainly not least, I'm thrilled to welcome back once again our global expert, Dr. Klaus Gorlinger. Dr. Gorlinger is one of the leading international experts in the management of coagulopathy, who has dedicated his career to perfecting the art and science of hemostatic resuscitation. Over 26 years of experience working as an anesthetist, intensivist, and hemostasiologist at the University Hospital Essen in Germany has imparted him with extensive knowledge in the fields of trauma surgery and emergency medicine, visceral surgery and liver transplantation, and thoracic and cardiovascular surgery. His main passion of research is the development and implementation of point-of-care guided algorithms for goal-directed perioperative bleeding management and patient blood management. He has published 91 PubMed listed papers, as well as numerous abstracts and book chapters. If you haven't already, please be sure to check out our event page for Dr. Gorlinger's full bio, as well as links to some recent COVID-19 associated coagulopathy podcasts and review papers. We have some really great resources available for you there. So tonight, Dr. Gorlinger will be presenting some of the latest research and studies highlighting the value of ROTEM in management of COVID-19 associated coagulopathy. So without further ado, please welcome back Dr. Klaus Gorlinger, and thank you so much for joining us again, Dr. Gorlinger. Over to you.
Yeah, thanks, Maggie, for your kind introduction. So I will share my screen and hope that everybody can see the slides.
Yes.
Okay. So as you mentioned, the topic is ROTEM in COVID-19, and yeah, it's more than a year ago that the pandemic started, and a lot of people recognized quite early that in this infection, there is a big impact on the coagulation system. This is just my disclosure. You heard already about my background, and most important for the conflict of interest is that since July 2012, I'm the global medical director of TEM Innovations, ROTEM company. As Maggie mentioned, we will have some poll questions within the presentation just to get the question and to answer them. Here's the link you need on your smartphone or on your computer. Then the questions will automatically send to you, and you can just respond and we will see the result within the slides. So I just give you some seconds to enter this link to your browser in your smartphone, that it's possible for you to answer. As Maggie mentioned, it's not a very difficult question. It's just to get it a little bit interactive and get your feedback. What do you think about COVID-19 associated coagulopathy? So I hope that everybody had the time to enter this into your browser. So we just go to the next slide. Yeah, going a little bit back in history, about 150 years ago, Rudolf Virchow, who was a pathologist at the Charité in Berlin, more or less described first the Virchow triad of thrombosis, which looks at the macropathology aspect of thrombosis. And he identified three important issues. One is an issue in blood flow. And we know that if we have a hemodynamic disruption or stasis, this, of course, supports the development of thrombosis. The second point is that blood itself can have some issues that can be hereditary issues, for example, factor V Leiden mutation, a prothrombin mutation, a low antithrombin or protein C, protein S, but they can also be acquired issues. And we all know that infection as well as inflammation are procoagulant situations where, for example, fibrinogen levels as well as platelets increase, and also sometimes factor VIII as an acute phase reactant is very high, which can also support thrombosis. And third, and that might be at that time most straightforward, was also that he identified that the vessel wall plays an important role. And in between, we know that usually endothelial cells and the microcirculation have anticoagulant properties, and in severe infection, this can move to a procoagulant situation. As mentioned before, very early in the first wave of COVID-19 last year, it was already identified that a lot of these patients have thrombosis, and in particular in the pulmonary system. So this was first interpreted as a pulmonary embolism, but a lot of these patients don't have deep vein thrombosis as a source for the pulmonary embolism. So nowadays, we know more that this thrombosis is more or less generated directly in the pulmonary vascular system. And one reason for this seems to be the damage which the virus induces to endothelial cells in this part of the body. And then maybe there's a vicious circle that, of course, the damage results in thrombosis and additional damage is generated. and then more and more thromboembolic complications can occur. And we call also this kind of thrombosis an immunothrombosis. This means that inflammatory cells play a very important role in this kind of thrombosis. Of course, we learned already more than 10 years ago that cells play a major role, and we move from the cascade model of hemostasis to the cell-based model of hemostasis. But again, in particular, in these cases with immunothrombosis, even the inflammatory cells play a very important role. And usually even in a cell-based model, we don't talk so much about leukocytes or monocytes or neutrophils, but they again are very important here, because we know that pathogen-associated molecular patterns as well as damage-associated molecular patterns can activate, for example, the monocytes, and this results in tissue factor expression on these cells, and the same happens on endothelial cells. What I mentioned, that they move from an anticoagulant behavior to a procoagulant behavior, and also there are microparticles develops which also present tissue factor. So that means that there is an activation of coagulation even without a direct mechanically damage to the vessel wall. Here's more a damage to the virus. And also other cells like neutrophils can release a lot of substances which have a procoagulant effect, and of course also platelets play an important role here. So that means inflammation and coagulation have a very important crosstalk, in particular in this kind of disease. Sorry. And this brings us to the first poll question. So the question is, COVID-19 associated coagulopathy is not characterized by inflammation, pulmonary thrombosis, disseminated intravascular coagulation, heparin resistance, or respiratory failure. So let's see what you think about this question. I hope it's more than one person who is able to answer. Yeah, it's at least, yeah. Now we have some people thinking heparin resistance is not an issue and respiratory failure is not an issue. So we give you some more seconds to vote. Some others say DIC is not an issue. It seems that everybody agrees that inflammation, yes, that's an issue. Pulmonary thrombosis is also an issue. I agree on both. And yeah, let's more or less stop here. And what we learned is that DIC is not usually, at least not in the beginning, an issue in COVID-19. That's a big difference to bacterial sepsis, where DIC starts quite early and clot firmness is decreasing and a predictor of high mortality. This is not typical for COVID-19 associated coagulopathy, so C would be the right answer. On the other hand, heparin resistance is observed very often, so that we give heparin, but heparin seems not to work adequately. And we will discuss later what's the reason for that. It's not a low antithrombin as we see it in bacterial sepsis. It seems to be more the very high levels of fibrinogen factor 8 and platelets, which results in heparin resistance. Of course, respiratory failure, we know that that's typical for COVID-19, that we have to put the patients in severe cases on a ventilator. So this is just a review paper which summarizes what is the change in viscoelastic testing, what we can observe. The point is that, of course, people were also focusing in the beginning on standard lab tests like PT and PTT, but there's usually not a big change. So there's not a significant difference between patient with and without COVID-19. What is typical with COVID-19 is this hypercoagulative state, which is usually characterized by an increased clot firmness. So nearly all COVID-19 patients, at least the hospitalized patients, have a clot firmness in extent, which is higher than 68. The severe case is even higher than 74. And FIB-10 is also usually above the normal range, so higher than 24, and most severe COVID-19 patients even higher than 30. So that's what we see, for example, here with this very strong FIB-10, which, usually FIB-10 doesn't even change from magenta to blue, but in COVID-19 patients, this happens quite early. And we will also discuss later on our other specific changes, for example, also changes in fibrinolysis. And it was, of course, a quite early question, and here discussed from the group from Karolinska University in Stockholm, if we measure a ROTEM at admission to the hospital, can we predict if this patient can be treated on the normal ward or will need a specialized ward with a possibility for mechanical ventilation? And again, what they showed was that all the COVID-19 patients had increased clot firmness, but already at admission to the hospital, they could discriminate the patients who could be treated on the normal ward. And as mentioned before, usually they have just a clot firmness of 68 to 70, where the patients who will need an ICU bed and mechanical ventilation usually are in the range of about 74 to 76 or even higher. And even more, the difference in FIB-10 MCF was quite predictive or discriminative to say if the patient will need just a normal ward or an ICU bed. And in particular, at the time of the first wave, where in Italy and Spain, a lot of hospitals were overwhelmed with patients. This is, of course, an important information to plan your hospital resources in the best way. And this was also the reason why we started the ROHOCO trial, which means a ROTEM sigma in hospitalized COVID-19 patients. Overall, it has been 10 countries with 14 hospitals, and we just finalized recruitment some weeks ago. So finally, it was a little bit more than 600 patients, where we want to look at more or less the same what Karolinska did, but this was just a little bit more than 60 patients. And of course, to do a precise prediction, you need a bigger number of patients. And the question here was also, by looking at the ROTEM analyzer as well as other coagulation biomarkers like D-dimers, how good can we predict if the patient will need an ICU bed, a ventilator, ECMO, or finally, what will be the outcome? Will he recover and can be discharged from hospital, or will he die in hospital? So we are just started to analyze this data. I mentioned already that there's another very important point in COVID-19, and that's a fibrolytic system. This is not a completely new information because we did already some studies 10 years ago in bacterial sepsis and could identify at that time that a fibrolytic shutdown, this means less than physiologic lysis, which is usually between 3 and 8% lysis within 1 hour. If this is even less, also in bacterial sepsis, it was the best predictor for mortality, much better than, for example, procalcitonin. And of course, people were looking also at this biomarker in COVID-19. One of the first was a group from Roman Snininski, who is one of the editors of Anesthesia and Analgesia. And they published that, again, when you use the XTEM maximum lysis within 60 minutes runtime with a cutoff of 3.5%, were a very good discriminator between patients who developed a thrombosis, that were the patient below 3.5% lysis within 1 hour, and the patient here in the blue box, we don't develop thrombosis. And they could show that 8 out of 9 patients, so 89% of the patient with venous thrombosis met the criteria of fibrolytic shutdown. Of course, that means you have to run your analysis at least 60 minutes to see these results. And we will discuss later why we need this time. Coming back to the Charité, where again, Rudolf Virchow 150 years ago developed the Virchow triad of thrombosis, or first described, there's another interesting study from Jan Kruse, published in December last year, who looked again at the prediction of thrombosis in COVID-19. And what he found out was that the combination of fibrolytic shutdown in ROTEM and D-dimers, increased D-dimers, were the best predictor of thrombosis in COVID-19. Just coming back to the thromboelastometry curve, and there's sometimes some confusion about parameters used on TEC and ROTEM for lysis, in particular about timing. And when we talk, for example, in ROTEM, about a lysis index 30. 30 means 30 minutes after clotting time, and 60 means 60 minutes after clotting time. You see that usually it takes about 25 to 30 minutes to even get to the maximum amplitude. And that means, of course, we cannot use already the lysis index 30 to identify fibrolytic shutdown. So we have to wait about half an hour after the maximum amplitude, which is about 60 minutes after clotting time. The confusing point is that if we look at TEC parameters, and they talk about lysis 30, this is 30 minutes after maximum amplitude. So more or less the TEC lysis 30 corresponds from timing to the ROTEM lysis index 60. But that is sometimes a little bit confusing. But again, to see if there's really no fibrolysis or less than physiologic, we need a runtime in both systems of about 60 minutes. And we see here in case B that there's a very strong clot and there's nearly no reduction of clot firmness over 1 hour, where we see in the second case, this is a physiologic lysis. So that's something between 3 and 8%. So this is not pathologic. This is what normally happens. It's just to explain and understand the results. Of course, they were also looking at standard lab tests in the group here, and the first group with thromboembolic events and the second group without thromboembolic events. And you see that platelet count is not really helpful, even the fibrinogen level, because the fibrinogen level is always high. And we will see this for FibTem is the same. So if you want to discriminate COVID-19 patients from non-COVID-19 patients, yes, fibrinogen can be used as well as FibTem. But within the COVID-19 group, to discriminate the patient with or without thrombosis, it's not really helpful. D-dimers can help, and you see that there is a significant difference. At best, it helps to look at the maximum D-dimer. That's nice in a study because you have all the results for the whole course of the case. In real clinical practice, it's a little bit difficult because you don't know what will be the D-dimers tomorrow. But again, D-dimers are quite helpful. Also, CRP as an inflammatory marker can help. It was a little bit surprised that IL-6 was not really predictive. You see the value is more or less doubled, but the variation here is so high in both groups that if you look at a big population, yes, you might discriminate, but case by case, it's very difficult to do a correct interpretation of the IL-6 values. Another surprise was in particular when we later see that fibrolysis markers in ROTEM are definitely helpful, that the classically marker like TPA or PI1, again, don't show a significant difference. Because it might be the relationship between both and not the absolute values, which shows that maybe there is a fibrolytic shutdown. So again, looking at ROTEM results, as mentioned before, FibTEM MCF and XTEM MCF is always high in critical ill patients with COVID-19. You see it's a 35 or 34, 75, 76, but they didn't allow in critical ill patients to discriminate between patients who develop thrombosis or not. There was a significant difference in in-term clotting time, but we have to be careful here because, of course, the patients who develop the thrombosis gets more heparin. So I think this is not the reason for thrombosis. That's just the more or less the result of the treatment. But the most important information is here when we look again at the maximum lysis, and you can use XTEM or INTEM, doesn't make a big difference. You see that in the patient with thromboembolic events, it was only 3% or 2% within 60 minutes, where it was in the patient without thromboembolic events in the physiologic range of 5 to 6. So, of course, we see hypercoagulability as a basic issue, but to discriminate whether the patients develop thrombosis or not, severe hypofibrolysis seems to be the key measurement. And when we look at the ROC curve analysis, again, we see, as mentioned before, D-dimers have already a predictive value. So the ROC area under the curve is 0.78, which is quite good. If we only look at fibrolytic shutdown, it's at least at the same level with 0.8. But if we combine both, and what the authors did was to calculate the difference between maximum D-dimer in milligram per liter minus maximum lysis in XTEM over 60 minutes in percent, and then with a cutoff of 3.7, they had a prediction of 92%. Whether the patient develops thrombosis. And it was quite high sensitivity with 94%, and also specificity was higher than 90%. So that's actually the best predictor of thrombosis in COVID-19. That's just, let's say, a recommendation from my side, because the problem is, again, maximum lysis depends on the runtime. So I think it's more standardized if we use a lysis index 60, because that's definitely always 60 minutes after clotting time. But you know, the lysis index represents the residual clot firmness at 60 minutes. So therefore, if we can recalculate the maximum lysis is lysis index 60 and XTEM minus 100. And then we have specifically the maximum lysis at 60 minutes after the clotting time. These results have been confirmed also by other groups. So that's from our hospital in Essen, where also they were looking at the similar prediction of thrombosis. And here again, the hypercoagulability on the one hand, but in particular also fibrolytic shutdown. This was a combination which was associated with the highest rate of thromboembolic events. So what we did more or less in the last 1 to 1.5 years was moving from the macropathology point of view from Rudolf Virchow, described 150 years, to now the micropathology view on thrombosis and COVID-19. And this is well reflected, as mentioned, in ROTEM results. First of all, also, but for this we have to use non-activated tests. We can measure tissue factor expression on circulating cells, where we use the native test with heparinase. Why with heparinase? Because also when you damage endothelial cells and the corresponding glycocalyx, you might have endogenous heparin-like effects, and this interfere with the measurement of tissue factors. So if we use a native test with heparinase, we can eliminate this interference. Then, as I mentioned before, hypercoagulability is something which happens to nearly every patient with COVID-19 associated coagulopathy. And as mentioned before, DIC with a reduction of clot firmness happens very late, but we will come back to this also when we discuss the management. And one of the key points is really hypofibrolysis or fibrolytic shutdown with less than 3.5% lysis within 60 minutes. And quite interesting, this even results to a recommendation from the FDA. It was for me the first time that FDA was recommending something which was not approved by the FDA. And you know, in the US, you need an approval of the device for every specific indication. So of course, actually no viscoelastic testing device is approved from the FDA for COVID-19, but in January, they clearly recommended the use of viscoelastic testing because it allows, first of all, the identification of hypercoagulability not reflected by standard lab tests, and second, also fibrolytic shutdown. So the opinion of the FDA was, even if viscoelastic testing devices like TEC or ROTEM are not specifically licensed in the US for COVID-19, the risk of harm is higher if you don't use them than to use them off-label. And this brings us to the second poll question, which is asking, thrombosis in COVID-19 associated coagulopathy is at best predicted by D dimers higher than 0.5 milligrams per liter, an APTT of less than 35 seconds, an XTEM MCF of more than 68 millimeters, a FIBTEM MCF of more than 24, or the combination of D dimers and a fibrolytic shutdown. So I give you some more seconds to vote. Actually, everybody says it's a combination of D dimers and fibrolytic shutdown in ROTEM. So this looks to me that somebody was listening. Yes, that's fine. Of course, D dimers alone play a role, but nearly all COVID-19 patients have a D dimer higher than 0.5. So this is again also not a discriminator between thrombosis or no thrombosis. Usually the patient with thrombosis are in the area of at least 4, 5, or even higher milligrams per liter. APTT usually doesn't change. And again, of course, the COVID-19 patients show hypercoagulability, and this discriminates COVID patients, for example, from bacterial sepsis patients, which has much lower clot firmness, but it doesn't discriminate alone between thrombosis and no thrombosis. So you are 100% right. That's fine to me. Now we are moving to some specific questions, how we should manage these cases, in particular, of course, the hospitalized or even more the critical ill cases. And one issue I mentioned already is that not every COVID-19 patient responds very well to our anticoagulant therapy, because even if we put everybody on thromboprophylaxis, still there's about 40 to 60% of the patients who develop a thrombosis. So the main question is it enough to put them just on thromboprophylaxis, or do we need intermediate or even therapeutic anticoagulation? And should we put some patients on alternative anticoagulation? So, for example, DOACs or IV direct thrombin inhibitors like agatoban or bivalirudin. The later, of course, more for the patients at the ICU. So what are the data which we have available? And actually, there are at least 10 randomized trials running. So this is not a randomized trial, that's a cohort study. And it was, let's say, quite optimistic that if we put the patient on high dosages of anticoagulation, so that means either intermediate or therapeutic, that they found that these patients have less thromboembolic complications and also less pulmonary embolism. So the high dose prophylactic anticoagulation in this study was associated with a significant reduced risk of thromboembolic complication with a hazard ratio of 0.81, which was significant. It was just significant. The authors concluded that it was without increased risk of bleeding, because here the 95% confidential interval crossed the zero line. However, we see there's a 19% reduction in risk of thrombosis and 11% risk increase for bleeding. So we have to be careful if this study was really powered enough to see whether these risk of bleeding increases significantly or not. And when we look at other studies, they show just the opposite, that there was also an increased risk of bleeding, in particular in the critical ill patients treated with subtherapeutic or therapeutic anticoagulation. So in this study, they had a significantly increased rate of bleeding, and in this population also an increased risk of mortality. So here you see that mortality increased from 15.3 to 41.6. Or when we look at the odds ratio, it's a 6-fold increase in mortality. However, here, of course, the question was, were just the patients who get therapeutic anticoagulation more severely ill? So is that not related to anticoagulation itself, or it's a direct effect of anticoagulation? So they looked more into detail of their data, and they compared, of course, the bleeding risk when they compared therapeutic dose to prophylactic dose. So bleeding incidence was 2% in patients just with thromboprophylaxis and 11% in the therapeutic dose. But there's an agreement that no thromboprophylaxis, so no anticoagulation at all, is not really an option anymore. So it's more interesting to look at therapeutic versus prophylactic. That's 4% versus 11%. So yes, there is an increase in bleeding complications in the therapeutic group. However, the question is still, is that really responsible for the increased mortality? So they were also looking at the relationship between bleeding and death. And what we see here quite nicely is that if patients develop major bleeding or even CNS bleeding, then the mortality increases from about 21% to 40 to 100%. So these complications are definitely associated with an increased mortality, where GI bleeding, we see there's no increase in mortality. So that means, yes, if patients really develop major bleeding under therapeutic anticoagulation in COVID-19 or intracerebral bleeding, yes, this is associated with increased mortality. Of course, people were also looking, what is the best drug to use for anticoagulation? And actually in this study, and other studies are running, showed that there are actually 2 drugs, and one is low molecular weight heparin, and the other is apixaban, which seem to have, at least in this study, the best effect on outcome, better than standard heparin. And we see a significant decrease in mortality with a prophylactic use of apixaban, with an odds ratio for mortality of 0.46, and enoxaparin with an odds ratio of 0.49. So this study doesn't provide a significant difference between both enoxaparin and apixaban. But finally, there's still the question, if a patient doesn't respond well to enoxaparin or another low molecular weight heparin, if it provides some value to move to a direct oral anticoagulant, which is not dependent, for example, on antithrombin. What they could also show that was the higher the D dimers were, the better was the improvement on mortality. So we see here if D dimers are below 1 microgram per milliliter or 1 milligram per liter, there was not really a significant beneficial effect. And it was even higher than 10. The benefit was highest. And that fits quite well also to the study from Jan Kruse, that it's more the D dimers which are even higher than 4 or 5 and combined with fibrolytic shutdown who benefits most from a therapeutic anticoagulation. So coming to the issue of heparin resistance, we know this from cardiac surgery quite well, that some patients, when we give heparin, even in very high dosages, we don't reach the ACT. We want to have to put the patient on cardiopulmonary bypass. And here we learn that antithrombin can be key. But in COVID-19, as mentioned, antithrombin is stable over a quite long time. So it's usually higher than 70 to 80%. So that seems not to be the main reason for heparin resistance. It's more the very high fibrinogen levels and platelet count. So also platelet count compared to bacterial sepsis, where it's dropping down quite early, is stable over a long time. And even some patients have very high platelet counts. So these hypercoagulability generated by a lot of platelets, a lot of fibrinogen, and also thrombin generation can increase because factor VIII as a very fast acute phase reactant went up. Another point is, let's say, the inflammatory baseline level of the patient. And we know that older patients have a much worse course in COVID-19. And one reason are, of course, comorbidities, and in particular also inflammatory diseases, which can also result in more heparin resistance. And what we at least doing in Europe and also in Germany, that we are quite liberal, in particular in the critically ill patients. And of course, also if we have to put patients on ECMO, to move early or even start with direct thrombin inhibitors, giving intravenously. So in Europe, we prefer here agatoban, which is of course typically used in heparin-induced thrombocytopenia, but we also use it early in patients where we see or suspect a heparin resistance, because again, the direct thrombin inhibitors are independent from antithrombin. But we will discuss what kind of monitoring we need. And there's other studies, also one randomized trial actually running also with bivalirudin that's more used in the US. I think it also depends on the price, because agatoban is usually cheaper in Europe and bivalirudin is cheaper in the US. They have the same a way to work. Both are direct thrombin inhibitors, and you see that most often they are monitored by APTT with a target of 45 to 70 seconds. But there is a big issue by using APTT, because the typical therapeutic range is here somewhere between 250 and 500 nanograms per milliliter. And you see in this range, the curve is extremely flat. So you can have the same PTT results with 250 or 2000 nanograms per milliliter. And you see correlation, so R square to the plasma concentration of agapan is only 0.28. So this is not really useful, and you cannot really identify an overdose, which can result in bleeding complications. And since we use, as I mentioned, agatoban already for a long time, Martin Beidel is a colleague who worked also in Essen, now is a chair in Osnabrück. And he did a randomized trial years ago that was, of course, not in COVID-19, but in critical ill patients who needed alternative anticoagulation. And he compared using the APTT, which is still more or less the standard of care. And you see again an R of 0.21 or 0.18. And if you just use the standard ROTEM test, the XTEM, you have a correlation of 0.71 or 0.76 if you use the absolute value or the ratio. So that shows monitoring is already much better using an XTEM clotting time compared to APTT. And what we just did, but it's not published already, is also using for agatoban, as mentioned before, the XTEM clotting time for agatoban and bivalirudin, or the acarine-based test. And now you see we talk about an R square of 0.94, 0.97, 0.92, 0.86. So this provides really a very good correlation. And you see even here, we were not just looking up to 2 micrograms per milliliter as in this PTT study. We even go to 4, or with bivalirudin to 16. So even in extremely high levels, we have a very good monitoring of these drugs. As mentioned before, actually there are a lot of studies, randomized trials running, looking at different anticoagulation strategies. As you see, there are 2 studies at least running using the direct thrombin inhibitors, giving by intravenous infusion, bivalirudin and agatoban. The Freedom study is looking at apixaban, a Brazilian study as rivaroxaban. There's also another study looking at fibrolytic therapy, and the other study is more comparing dosing of low molecular weight heparin or heparin. So within the next month, we will get, I think, a lot of additional information. What is also quite interesting that most guidelines recommend to use anti-10A to monitor your unfractionated heparin or low molecular weight heparin. And the reason is that, again, a lot of patients don't respond well. That means if we don't see any increase in anti-10A activity, we can interpret this as a heparin resistance and have to think of changing the dosing or moving to an alternative anticoagulation. So what is the alternative if we don't have anti-10A 24/7 available? And these are data from a cardiac surgery study from Japan. And what they wanted to do was after giving protamine, so here we are talking about low anti-10A activities, as in intermediate or therapeutic anticoagulation, you know, the target is usually between 0.3, 0.6 for intermediate and 0.6 to 1.0 anti-10A activity for therapeutic anticoagulation. Here they were looking for residual heparin effects. And they compared, or they used anti-10A as a gold standard, and then they looked at the correlation to the INTEM to HEPTEM clotting time ratio, which has an R value of 0.72 to anti-10A. ACT has an R of 0.12 and APTT of 0.36. So here the INTEM to HEPTEM clotting time ratio had the best correlation to the anti-10A values. And what was also shown that if anti-10A was below 0.2, there was no correlation to bleeding in cardiac surgery. So coming back to the randomized trials, which are actually running, and the 3 of these randomized trials looking at different dosing of heparin. So to use in one arm therapeutic anticoagulation and the other arm on just thromboprophylaxis, did planned interim analysis in December and January. And there were some, let's say, surprising results, because up to now we were using an escalating concept, which means most patients at the normal ward just get thromboprophylaxis. And if the severity of the disease increased and they need organ support, going to the ICU, most of the patients get a higher dose of heparin. But what they could show was that giving patient with severe COVID-19, so that's a critical ill patient at the ICU, therapeutic doses of heparin showed some increase in mortality. So the odds ratio for survival or decreased need for organ support was 0.76. And one reason might be that the incidence of bleeding complications was much higher in some critical ill patients. And the reason for this might be that in a late stage with DIC or with organ failure, even clot firmness is decreasing, and where it's more stable in the patient at the normal ward. On the other hand, when we look at the patients at the normal ward, so before they develop severe complications, patients with therapeutic anticoagulation had a significant increased survival. So that was increased by about 60%. And the bleeding complications in this population with a very stable hypercoagulability was quite low. And that is actually changing the idea or the overall concept to a de-escalating concept. The point what we have to understand in this study at the time of randomization, when they were randomized already at the normal ward, that means if you start with therapeutic anticoagulation, you continue the therapeutic anticoagulation at the ICU, where when you randomize patients which are already at the ICU, this makes a difference. So it's not that during the protocol, all patients who moved from the normal ward to the ICU and where they had in the beginning therapeutic anticoagulation that were decreased. So of course, there are still unanswered questions. And one important question is whether and when to de-escalate therapeutic anticoagulation in critical ill COVID-19 patients. So, and that means we need an individualized assessment of patients' risk of thrombosis and bleeding. And the higher intensity of anticoagulation might be preferred in patients who are just to be at high risk of thrombosis, but we might have to de-escalate the patients who are at high risk of bleeding. So this means really a paradigm shift in anticoagulation in COVID-19. Again, what we did in the last year, most of the time, was escalating concept. That means starts with a low dose in the normal ward, increase at the ICU. And the main question is which patient is at risk of thrombosis? Now, by moving to a de-escalating concept, which means we should start in hospitalized patients with COVID-19 immediately with therapeutic anticoagulation. The question is more when the patient has to be transferred to the ICU to identify in this critical ill patient, the patients with an increased bleeding risk. So the question is changing completely. But this is even where we have more experience in a lot of settings to identify the patients are bleeding. What is also important that we keep an eye on the dynamics, because it makes a big difference if we measure just on one day, let's say a clot firmness in XM of 70 millimeters. It depends where we are coming from. If the day before or 2 days before clot firmness was just 65 and now it's 70, we have an increasing clot firmness, which shows that there is a higher risk of bleeding. Where if it's just the opposite, the patient is coming from 75 and now it's 68, then we have a decreasing clot firmness, which may mean that the patient went into the risk of bleeding. So to look at the dynamics is very important. And that results also here in this recommendation from a group from the US. Paul Gurbel did a lot of scientific work, in particular in cardiology. And what they are also recommending is using viscoelastic testing, so TEC or ROTEM. And I think at best in combination with our biomarkers like D-dimers to individualize therapy. And again, it's not based on just one single value. We have also to look at the dynamics and of course also the clinical situation of the patients. And I have here just two cases to show the difference. In the first case, of course, we have a very high clot firmness, so XTEM MCF is 78 millimeters. And FIBTEM MCF is 50. So more or less, this patient can even clot without platelets. But the good point is there is no fibrolytic shutdown. So in XSTEM, we have 7% lysis over 1 hour. So that's exactly in the physiologic range. And when we look at the clinical condition of these patients, yes, this patient has hypercoagulability, received therapeutic dose of low molecular weight heparin, recovered well, and was discharged from the ICU 5 days later, and also later on was discharged from hospital. When we just look at clot firmness, this looks much more normal. So here we have only an MCF in XSTEM of 48 and in FIBTEM of 14, but we have fibrolytic shutdown. So maximum lysis in XSTEM only 2% and in FIBTEM 0%. And this patient, even if it had no comorbidities, deteriorated very quickly, had multiple organ failure within 36 hours and passed away some hours later. So that means having just this snapshot doesn't help us a lot, because it seems to be already the decreasing part of clot firmness and has a fibrolytic shutdown, which is very important for the prognosis. So just to summarize how rotational thromboelastometry can help in COVID-19, which we summarized in the review papers some weeks ago. First of all, yes, we have the possibility by using anti-10A activity or the INTEM to HEPTEM clotting time ratio of a low molecular weight heparin, the native test with and without heparinase, to see if heparin has an effect or not. Looking at fibrinogen or FIBTEM MCF has a very good correlation to CRP and IL-6 levels. So it is a good marker for the inflammatory status. Hypercoagulability can at best described by the XSTEM MCF. Typically, in hospitalized COVID-19 patients higher than 68, or in critical ill patients higher than 74. And as mentioned before, hypothrombolysis or fibrolytic shutdown, in particular in combination with increased D dimers, are a very good predictor of thromboembolic complications. So what we need is to look at the pattern, and for this we have to combine viscoelastic testing with standard biomarkers like D dimers. What I tried to do with this table, and this is not always already evidence-based and clear cutoff values, but it should just summarize which parameters can help us in the decision-making, whether this individual patient has a higher risk of bleeding or a higher risk of thrombosis. So again, of course, a combination D dimer and reduced lysis with this cutoff value of 3.7 can identify quite nicely patients with increased risk of thrombosis. XSTEM lysis alone can also be used, as well as D dimers, but the performance is not the same as in the combination. As mentioned before, CRP as an inflammatory marker can be helpful. And on the other hand, the clot firmness in XSTEM as well as in FIBTEM shows, of course, hypercoagulability, but on the other hand, also hypocoagulability. So it can be used for both prediction of thrombotic as bleeding risk, and as mentioned before, the dynamic is very important. Also, what we see in very severely ill COVID-19 patients, that the prolongation of the clotting time, which happens late, can be a marker of bleeding risk as well as poor outcome. And again, as mentioned before, anti-10A levels as well as clotting time ratios on ROTEM can be used to see if the patient responds well and gets into the targeted range in our anticoagulation. So therefore, coming to the third poll questions, which statement about anticoagulation in COVID-19 is correct? A, every hospitalized COVID-19 patient should receive at least thromboprophylaxis. Or B, Thrombosis is not an issue in hospitalized COVID-19 patients. C, bleeding is not an issue in critically ill COVID-19 patients. D, heparin resistance is not an issue in hospitalized COVID-19 patients. And E, antithrombin decreases early in hospitalized COVID-19 patients. So I just give some seconds more if there's anybody has a different opinion compared to, yes, there's somebody. So heparin resistance is not an issue in hospitalized COVID-19 patients, 20%. Yeah, we can, I think, maybe stop here, and somebody just changed the mind. And I agree that, yeah, that is the minimum agreement that every hospitalized patient should receive at least thromboprophylaxis. The guidelines did not change already due to the 3 randomized trials, because that was a planned interim analysis. And the group from the guideline committees agreed that we should change the guidelines when we have the final results from these studies. But then I think it will move, if the final results are the same as the interim results, that we should start early in hospitalized patients with therapeutic anticoagulation. And then we have to decide later on at the ICU, if the coagulation system is going down, that we might have to decrease to intermediate or prophylactic dosages in some patients. The last part is another question. We discussed the dosage of anticoagulation and also the drugs. In the situation where we cannot really oxygenate the patient anymore, despite optimized mechanical ventilation and prone position, we finally only have 3 options anymore. Do nothing and that patient die, or we can try a fibrolytic therapy or put the patient on ECMO. And we know that all of these options have a very high mortality rate. So I just try to explain how, again, maybe parameters can help for the decision making. So when we look at the results, actually, or that's a discussion of the possibility using fibrolytic therapy, there are some case series who showed some promising results, that at least if you give thrombolytic drugs like TPA, you can improve oxygenation. But of course, finally, the question is, can we also improve outcome? So this is still under discussion, and there are also randomized trials actually running. For example, here from Ernest and Hunter Moore, coming mainly from trauma, but have a lot of experience in monitoring thrombolysis and also doing fibrolytic therapy. There's one issue at what we know already also from all the studies here from Paulo Simeone's group, looking at patients just with ischemic stroke and performing thrombolytic therapy, that they could show that if the FibTem is below 13 to 14.5, so the optimum cutoff in ROC analyze was 13.5, if it's below, we have an extremely high rate of hemorrhagic stroke as a complication. So that means if FibTem decreased already below 13.5, this is not a good idea to do thrombolytic therapy, because having a hemorrhagic stroke is definitely a complication, which has been shown in studies before with more or less 100% mortality in COVID-19. The other point is, what should we target? We don't want to do a very aggressive thrombolytic therapy so that we see systemically a hyperthrombolysis. The target is to just go into the physiologic range. So as I mentioned before, something between 3 and 10%, so in mean 8%, then we have a very low rate of hemorrhagic complications, where if we go to a level of 14% lysis or even more, this is associated with a lot of bleeding complications. So we can use the ROTEM, first of all, to exclude patients with a very high bleeding risk from fibrolytic therapy. And we can also target our dosing by monitoring the amount of thrombolysis we induce. So when we look,
Gorlinger,
yeah,
sorry, this is your just a 5-minute reminder. We have some
that's
questions that
fine.
came
It's
through.
one
Thank
of the
you.
last slides. It's quite well. So of course there are some studies looking at the outcome of patients. It's a quite big group here from New York, 7,000 patients. From these 7,000 patients, more or less, that's 1% received thrombolytic therapy. So it was usually in this study used more or less very late. The good news was that 50% showed an improvement in oxygenation, but the bad news is there was more or less a 90% mortality rate. So if we do it very, very late, yes, the outcome is not very good. But it's more or less the same for ECMO. This is a study from the first wave from Spain, where also, one issue was that, of course, the ECMO devices were very limited, but even also when patients were put on ECMO, and this might be also because they were put on ECMO very late, the outcome was not good. But what they could show was that lymphocyte count, so if the lymphocyte count was very low or IL-6 was very high, this was a very good predictor for bad outcome. And of course, and that we know also from other patients with ECMO therapy, that we have to monitor coagulation very closely, because on ECMO, of course, there's a high risk of thrombotic issues, that we have problems with the oxygenator, or also have ischemic strokes, but also the bleeding risk is very high. And from these case series in COVID-19 patients put on ECMO, 4 out of 10 patients had a hemorrhagic stroke, and in 75%, this was associated with death. So that means, again, also mortality is very high, and in particular also bleeding complications are high. So we have to monitor these patients very closely. So we're coming to the last poll question: which statement about ECMO in COVID-19 is not correct? Is it A, ECMO in COVID-19 is associated with a high incidence of thrombotic events? Is it B, ECMO in COVID-19 is associated with a high incidence of bleeding complications? Is it C, ECMO in COVID-19 requires sophisticated hemostasis management? Or is it D, ECMO in COVID-19 is associated with low mortality? Or is it E, low lymphocyte count and high IL-6 levels predict increased mortality in COVID-19 patients on ECMO? So actually 1/3 or less, now it's only a little bit less up to 1/4, think that you need sophisticated hemostasis management. 70% thinks that ECMO in COVID-19 associated with low mortality. I think it's just the opposite. It's associated with a very high mortality of 80 to 90%. And the last point is just the opposite. So low lymphocyte count and high IL-6 levels predict high mortality. Okay. So what are the data available? How we can use, again, viscoelastic testing also in patients on ECMO? And of course, these are also studies which have been done already before COVID-19. That's a study from Helsinki. And what they could show, that if you put a patient on ECMO and you see already on the first perioperative day a significant drop in FibTem, this is associated with a very high mortality. So this is an issue if this drops down very quickly. And also for XTEM, there you have 2 time points. One is between day 1 and 2, and a second drop at day 5. So again, if we see these drops, this is associated with a high 30-day mortality. Another study that's from Innsbruck in Austria, from the group where also Dietmar Fries is working. They looked at different parameters. On the one hand, they looked at renal function, and we know, of course, there's also a link between renal function and coagulation. They looked at the PET, and they looked at platelet function, and in particular at the thrombin pathway. So it's nothing to do with antiplatelet drugs. It's more the general platelet function. And when we look at these three different parameters, all of them had some prediction on outcome. It's not very high. It's for creatinine 0.76, for PT 0.69, and for platelet function 0.76. But again, if we combine these parameters, like in the Cruises study combining D-dimers and fibrolytic shutdown, the combination has a very good prediction of 90%. So that means, again, I think we have to look at pattern, and there's not one single parameter which gives us all the information. And of course, coming back in the last study, I want to show to Australia, this is Sydney, the group from Hergen Buscher and Priya Nair. They did some time ago a pilot study. This was just a study to get some first results and to use these results for a power calculation for a bigger study. But it showed quite interesting results, again, which we can use for our power analyze. You see that in the ROTEM group, red blood cell transfusion decreased from 10 to 4 units, platelets from 3 to 1 unit, fresh frozen plasma from 2 to 0 unit, and cryo from 4 to 0 units. That's just transfusion. More important is the incidence of bleeding and thrombotic complications. And you see bleeding episodes goes down from 78 to 57%, and rebleeding from 86 to 50%. So there's a strong trend to less bleeding complications. And at the same time, a strong trend to less thrombotic complications, so from 56 to 14%, and the need to change the oxygenator from 22 to 0%. So again, we can use these results for a power analysis for a bigger randomized trial, but I think it's quite promising. But what we need, and that's exactly the situation also in COVID-19, we need a protocol which looks at both sides of the coin. It's not only bleeding or only thrombosis. We have to keep the patient in the, let's say, sweet spot or safe zone, which means, again, we have to look at hypercoagulability as well as hypocoagulability. And with this paradigm shift, even it's more important maybe later on in the critical ill patients to identify the patient where we have to decrease the anticoagulation. And I also try to summarize this information in this table. Again, this is not already an algorithm. It's just like a think tank. First of all, what are the clinical conditions? Of course, we're talking here about confirmed COVID-19. Of course, with severe lung injury, we don't think about ECMO or thrombolysis. If there's no problem to oxygenate the patients. Of course, there are also clear contraindications for both. Active bleeding, it's not a good idea to do thrombolytic therapy or ECMO. If there are known bleeding disorders or hemorrhagic stroke, also not a good idea for both. If patients have vascular malformations or a malignancy, which is even life-limiting, of course, this might be also a contraindication. But if we don't have a contraindication, but the indication, just have to decide what is a better therapy to choose, maybe these additional informations can help. And of course, if we have a confirmed or suspected pulmonary embolism, this is a quite good indication for thrombolytic therapy. Here, ECMO will not be very helpful. We can use, again, the combination of maximum D-dimers and fibrolytic shutdown, because if we see this with fibrolytic shutdown, it goes more to thrombolytic therapy rather than ECMO. Again, we can use also these single parameters. We know that if we have a lot of inflammation, can be increased CRP or increased IL-6. The prognosis on ECMO is very bad. We don't know what is exactly thrombosis in the prognosis in thrombolytic therapy. Lymphocyte count might help. And of course, we are more thinking about thrombolytic therapy if clot firmness is very high, where if clot firmness is already quite low, we might be more prone to ECMO. But if we see a decrease early on ECMO, it's again a bad prognostic sign. So that's a final slide. I think, of course, we cannot answer all the questions we have still about the treatment of COVID-19 associated coagulopathy. But what we know is that it's, of course, a very complex situation, like, for example, the metro map here in Barcelona, even more complex in Tokyo. And we can use ROTEM as a hemostasis navigation system. And the specific point in the metro map in Barcelona is there is one station which has a name clot. And if we don't get to this station, then and we don't get out here, we immediately get to Sagrada Familia, maybe to the graveyard. And that just shows, yes, we can use ROTEM to navigate our anticoagulation as well, our bleeding management also in COVID-19. And finally, it's not about transfusion. Finally, it's about patient safety. And of course, we learn every day more and we get more information. So also the knowledge about COVID-19 associated coagulopathy as a coagulopathy itself is very dynamic. And we have to try to keep at the best level of knowledge. And I hope I could contribute to this. And I'm happy, of course, to answer any questions. And thanks for your attention.
Thank you so much, Dr. Gorlinger. That was a really fantastic presentation. And we do already have one question from the chat. The question is, if pregnant women get COVID-19, would it be better for them to receive anticoagulation, or the decision has to be individualized?
Yeah, what we know is that also pregnancy is a risk factor for respiratory failure in COVID-19. I think it's a little bit from a pathophysiology like obesity that, of course, there is an increased intra-abdominal pressure and the diaphragm is quite high. So these patients develop earlier respiratory issues. Actually, the recommendation is to put them on thromboprophylaxis with low molecular weight heparin. Of course, you know, it's even more difficult to do studies in pregnant women. But yes, at least the prophylaxis should be done. And then I think we have to do also individual decisions to put them on high levels of anticoagulation is also, of course, associated with increased risk of bleeding. So we really have to individualize that. And I personally would recommend to use, for example, anti-10A to see where we are, if the patient responds or don't respond to the therapy, and then maybe we have to individualize the dose.
Thank you for that. Does anyone else have any more questions? Okay, it looks like that may have been the only one.
Maybe it was so clear, and I think that the response to the poll questions, I think, was quite good. Again, I think it's the knowledge is very dynamic, and 3 weeks ago, I had several presentations in Moscow, and the Monday presentation was completely different to the Friday presentation, because at that time, this information about the interim analysis of the randomized trials with low molecular weight heparin and therapeutic anticoagulation came out. And I think we will have to wait for the final results. But I think this will really be a game changer that, that we should be very proactive in the patients already on the normal ward. And I think the aim is more to prevent thrombosis, and most thrombosis developed already at the normal ward, and not so much to treat thrombosis at the ICU. So this seems to be the key information, again, if the final results will confirm the interim analysis. Of course, a similar question you can ask for thrombolytic therapy. So of course, if we have a severe pulmonary thrombosis in a 70-year-old patient, yeah, to chance to save a life, whatever, with thrombolytic therapy or with ECMO is relatively low. We all know. So the timing, again, I think will be very important. What is the right time to increase our therapy or to decrease the therapy?
Thank you again for that. I'll just ask one last time before we close out for tonight. If anyone else has any questions, feel free to speak up or pop it in the chat. And in the meantime, Dr. Gorlinger, do you have any other final comments before we close for the evening?
Yeah, as I mentioned before, timing is important, and there is not one single parameter which gives us all the answers. It's more showing that the future will be looking at patterns. And of course, we now start to analyze the ROCO trial with a quite huge population. And maybe even we get here information which then help us to guide therapy or do the best decision which we can do for our individual patients.
Perfect. Thank you again so much. I haven't seen any other questions come through, so we'll wrap it up there. This concludes tonight's Emerge event. We hope you all found this meeting to be thought-provoking and informative. Thank you again so much for taking time out of your busy evenings to join us. We really look forward to receiving your feedback on the follow-up surveys that we send. And also please be on the lookout for the invite to our next Emerge events for the topic of ROTEM and cardiac surgery. There will be a webinar and also a workshop for that one, and those will take place in early August. Thank you, Dr. Gorlinger, again so much. As always, we're so grateful for your time and your expertise and for making these events possible for us. Thank you so much. And once again, I'm Maggie Harrington, and from our whole WRFN Australia team, everyone's coming back on there in their video. We hope you all stay safe and healthy, and we look forward to seeing you at our next event. So thanks again, everyone, and good night.
Okay, bye-bye.
Bye, everyone.